but just for the talk. Thank you all for coming. It's my very great pleasure after a little bit of an interregnum where we didn't have a lecture for a couple of terms. We now have managed to instigate it, and I'm very grateful for Minoritized from the University of Bath, who's going to come and update us, because she did generously come and talk to the department about her single session interventions. But I think it's such an important issue and potentially transformative for services, given how long waiting lists are, that we're delighted to welcome her back. So without further ado, Maria, shall I hand over to you?
Yeah, thank you. And thank you so much for the invite to come back, Tamsin, and to all at the Charm group in Cambridge. So what I'll be talking to you about today is my work scaling out single session interventions and how we can really use those to improve access to help, especially early help for young people with depression symptoms in the UK. I'm always delighted to be invited to talk in Cambridge in particular. So just as a brief interlude, Cambridge for me is familiar stomping ground. So those of you who know your Cambridge colleges will spot that this is Trinity Hall. And I did my undergraduate at Trinity Hall, and back in 2004, graduated from social and political sciences. I subsequently worked both at Brookside CAMS and also at the Croft Children's Inpatient Unit. And I was involved a bit on the impact randomized controlled trial led by Ian, Raf, and other colleagues. And as a side note, I've since worked on several publications using impact study data, and also worked with various members of the Impact Consortium group in pulling together what felt a bit like a mammoth practitioner review for JAA-CAP that was published back in 2023, where we tried to really bring together all the things that we've learned from all the papers on the impact study. I'm not going to talk any about that today, but that was really where I grew my interest in working with young people with depression specifically. And it was many of the young people I saw in Brookside CAMS when I was working there as a jobbing junior clinical psychologist, who told me so much about how they'd struggled to get access to CAMS and how they wished they'd had help earlier, that really drove me on what is now my mission as a clinical academic researcher. And that's really to empower young people to develop, enjoy, and succeed. And I'm doing this program of work aimed at improving access to early help for young people with depression symptoms as part of my way to help young people out there to live the best lives they can. So what I'm going to do today is to first briefly talk about the problem that I'm trying to address through my work, which is the needs access gap. I know you're all really familiar with this, and some of your work is work that's informed me and my thinking, so I won't dwell on this. I will introduce to you the potential solution, which I did talk to your group about some before, but I'll remind you what this potential solution, or at least part of the solution as I see it, is, which is single session interventions. But really, I'll focus on telling you about what we've been doing here in the UK as part of my NIHR Advanced Fellowship Programme of work, and what we found in some of those studies. I have popped in the chat a whole load of links to some of the papers that I'll be mentioning today, and I've also sent those over to Holly, so she will share those with a copy of my slides as well afterwards with you as an aid memoir. So the problem is really the needs access gap, right? So this is my mind map of my thinking here. Essentially, we know that lots of young people, around about a quarter, depending on how we measure it and what we're counting, but around about a quarter of young people have elevated depression symptoms. That doesn't mean they all meet a diagnosis, but they have elevated depression symptoms. And we know that even when these symptoms are sub-threshold, they impact on functioning and get in the way of young people doing what they want to do in their lives. We know that there are effective treatments that can help, but there are barriers to young people seeking help. And these are both at the individual level. So things like the practicalities of how help is provided, multi-session therapies at clinics, often during 9 to 5 hours when young people are also at school or at college. Self-reliance, we know that young people, as part of their normative development during the adolescent stage, want to become autonomous and should become more autonomous and want to rely more on themselves. So that might get in the way of them reaching out and asking adults for help. We also know that even though things have improved, there is still a stigma around asking for help. And that is particularly so for young people from minority groups who might have stigma attached to another identity like sexual or gender minority or ethnic minority as well. We also know, though, that there are systemic barriers to young people accessing help. Those include the lack of trained therapists. And look, I've been working here at the University of Bath on the Doctorate in Clinical Psychology program, training more clinical psychologists for over a decade now. I've been involved in all sorts of the programs we've had running across the country, like the Child IAPT, and subsequently the mental health support teams in schools, the child wellbeing practitioners. I've been involved in all of those different programs in a bid to help train more people to provide psychological therapies that work for young people. But no matter how much we've trained people, we still find there are bottlenecks, there are thresholds for accessing services and gatekeeping, which means that young people need to go and ask often multiple different people in order to get access to help. We know that one of the solutions in this space, and one that was particularly accelerated in the context of the pandemic, was digital mental health interventions, DMHIs. Most of these are built so that we presume someone is going to keep accessing them over time, keep using them in order to gain the full benefit. And yet, particularly when these are self-help, which is the most scalable form and gets away from our problem of the lack of trained people to deliver them, we tend to find in real world contexts that young people, indeed adults too, tend to use digital mental health interventions only a couple of times, most commonly once. We find rates of use drop off dramatically as you progress through a number of sessions or modules on these kind of platforms. So we have got a problem that we don't have very much in the space of things that are designed for one-off use that are also available on demand, anonymously, and are evidence-based. And really, in all my formative work, talking to young people and all their supporters like clinicians, school staff, GPs, parents, but also in the wider priority setting exercises that have been done by different groups like the James Lind Alliance and some of the work in emerging minds, including through the advanced network that I was involved in. Really what we see is a consensus out there that there are two problems that we really need to tackle for young people in this space. One is we need to help young people and their supporters to get better at recognizing when help is needed at an early stage, but then also to connect them with the right help at the right time. And we know that these kind of things are especially hard for minoritized, stigmatized groups who are also particularly vulnerable to experiencing mental health problems. And we know that we need to front load things more. We've done more both in research and in services we've developed for those who are more moderately to severely affected, but those who are at that early stage, mild to moderate difficulties, before they might meet criteria for accessing services or for a diagnosis, we need to really front load support at that end. And so really then we need brief, scalable interventions as part of our landscape. Now, I really want to emphasize this. I don't see these as a replacement for anything else we've already got out there. And I think everything else in the ecosystem is also really important. And we need to continue to develop the evidence and develop the services across the board. But I do think that self-help single session interventions, which do not presume repeat attendance and are widely available anonymously, could be a useful extension to what we already currently provide. So let me tell you a bit about single session interventions and what we already know. What is a single session intervention? Well, a single session intervention is really what it sounds like. It's a one-off therapeutic intervention. So Wendy Dryden, who's done a lot of work in the space of single session therapy in the UK, has a lovely definition. So borrowing his definition, it's a purposeful endeavor where both parties, the therapist or the provider, and the client, the receiver, the user in the case of a digital mental health intervention, set out with the intention of the client being helped, the user being helped in that just one session. That doesn't mean that they can't access more help. There might well be a need to access more help further down the line, but we don't assume that they are necessarily going to do so. So it's designed to be kind of self-contained and to deliver whatever its key message or active ingredient is in that single session. Now, obviously, this can take various forms. So you can do single session therapies face-to-face as therapist delivered. You can do them for an individual or for groups, but you can also do them as self-help. And as I already mentioned, self-help is ultimately the most scalable. It's the way we can get away from this problem of lack of trained therapists. And it's a way we can make things available to young people at any time of day or night and when they need them without barriers. So really what I am working off of is super work that's been done already in the USA. And that's really been led by Jessica Schleider, whose group is called the Lab for Scalable Mental Health. When I first came across her work, which was via listening to a podcast in 2020, that time when we were all going for our one walk a day and, making the most of it, listening to a podcast from the Association of Child and Adolescent Mental Health, I first heard Jessica talking. And what Jessica and her group have done is develop this suite now of brief, anonymous, self-guided programs that are available online, specifically designed for young people's mental health, and they each teach different evidence-based ways of dealing with stress, anxiety, or depression. Each takes about 20 minutes to complete, and young people access them privately and entirely on their own terms. She based this work on a foundational meta-analysis she did as part of a systematic review process. So her starting point really was, what do we already know about whether single session interventions can help young people to overcome mental health problems? So this was back in 2017 when she found over 50 studies already in the space of young people's mental health that had used some kind of single session. Some were self-help, some were therapist delivered, but she found that overall, effect sizes were small, but promising. And given how scalable single session interventions are, small effect sizes at population level could be really impactful. And so on the basis of that, and also when she disentangled and compared those that had been self-help versus those that had been therapist-delivered single session interventions, she particularly noted that effect sizes were fairly comparable for those with the therapist delivered, those with self-help. So on the basis of that, she set out to develop initially one and subsequently a whole program of these single session self-help interventions. Now, each of them she's developed around a set of principles she now calls the best elements. And what this stands for is first B for brain science. I mean, what I understand this to be is psychoeducation. So this is essentially normalizing concepts, sharing what we know about something about a key ingredient of change in mental health. What also then is included in each of these single session interventions is activities to empower the young person. So things like they're given a little scenario of like, here's Johnny and he's 16 and he's struggling with this kind of problem that we've just told you about. How would you use the brain science to suggest he helps himself? So you're getting them to kind of engage in active learning. So we haven't just passively told them about something, we're now asking them to actively think about how that could apply. So this kind of gets into saying is believing, so solving these hypothetical situations based on what they've learned. And it also includes in each of these programs testimonials from valued others, so older peers, but also experts, to kind of really reinforce the key message of each of these packs. So if you're interested in looking at this suite a little bit more that they've already developed in the States, Jessica's group, the schleiderlab.org, have a great website where all of these things are freely available. They are absolutely committed to making everything openly accessible, and there's all sorts of fabulous resources there. You can look under the hood yourself at what's in all of these interventions. But I'll tell you a bit more now, and I'm going to specifically focus on the kind of top three here, but especially the top two. So the ABC project, the ABC standing for Action Brings Change, which is essentially behavior activation based. So the key message here is doing more of what matters can help you feel better. And also project personality. So project personality is growth mindset based. So helping young people to learn that they can learn how to think in different ways. I'll also briefly mention project care, and project care is self-kindness, self-compassion based. The reason I'm particularly going to focus in on telling you about the ABC project and project personality is because these are the two best tested to date, although evidence is continuing to evolve and the suite is continuing to grow. And I won't mention it further today, but a separate intervention that isn't yet on this suite, but we've been developing and piloting is called Project Sleep. And Project Sleep helps young people who might be struggling with their sleep, as you would imagine. So let me just show you a little more about what one of these programs looks like. Here I've just taken some screenshots from the ABC project single session intervention. All of these interventions are built in Qualtrics. So we host our measures in our research studies in that database, but we also use that as the platform on which these interventions exist currently. What that means is young people, users, don't need to download anything, don't need a particular kind of device. Any device that can connect to the internet, be it a phone, be it a computer, be it a tablet device, from anywhere in the world can access these interventions. They also don't need to talk to anyone to access them. And what they do is they work through a series of kind of slides. Think of this as an e-learning pack. We would never call it that to a young person because obviously the idea of an e-learning pack immediately creates horrors of schools and so on and so forth. It's a bit like calling things homework in CBT. But essentially, you know, it's an e-learning pack. It's like what we would build, or like what our mandatory training departments build for us as practitioners to work through to complete our mandatory training. So there's various information. Each of the pages has voiceover on it so that it's read out to the young person as well as it being written or text. So that helps with accessibility for young people who might struggle with reading particularly, but takes them through this variety of different exercises, getting them to engage in some active learning, like rate their mood, watch a funny video on YouTube, rate their mood again, see what happens, what do they learn about the connections between what you do and how you feel, so behaviors and feelings, and then kind of give them a scenario. In this case, it's Kat. What would you help Kat to do to get out of this negative spiral she's in? And then getting to action planning for themselves. Let's think about how you can start to take positive actions in your lives. You'll see on some of these snips that I've got here, there's a bit of a legacy from the pandemic times when some of these had been altered to think about socially distanced or virtual activities, but obviously we have updated versions now. So what's the evidence? What do we know already? Well, in the States, Jessica's team has really done quite a lot of robust evaluation. She's done a series of randomized control trials. If you're interested, if you have a look at her website, all her publications are there. But essentially, she's found that at up to 9 months later, we see young people who've had one of the single session interventions that's one of the active interventions, i.e. contains an active ingredient of what we think leads to change for youth mental health. We see young people up to 9 months later with reduced depression symptoms and other favorable outcomes like reduced anxiety symptoms in comparison, and this is important, in comparison to what she calls a placebo-controlled single-session intervention. So this is an intervention that is called the sharing feelings intervention. It looks and feels like one of these programs. It takes young people through a series of activities, but what it doesn't contain is an active ingredient of mental health. So it does all the kind of warm, supportive, non-specifics. So it's a really robust control. Now, of course, it's really unusual in psychology for us to be able to do that. And she does, in her trials, ask young people if they think they were allocated to the control condition. And on the whole, they don't know that they've been allocated to the control condition. So it's a fairly convincing equivalent of a tablet white pill placebo, as it were. The biggest trial she did was in the pandemic context. She recruited 2,500 young people in 3 weeks by Instagram. Now, I'm just still staggered by that. Instagram, 3 weeks, 2,500 young people signed up and did this intervention, aged 13 to 16. And they were from across all 50 states in the USA. They were randomized to either this placebo SSI or to ABC Project or to the growth mindset SSI Project personality. And the endpoint was 3 months later. And at 3 months later, small effect sizes, but reduced depression symptoms, also a whole load of other really interesting secondary outcomes like reduced restrictive eating 3 months later. Yeah, really, really interesting. She found that the 2 active interventions, ABC Project and Project Personality, were equally good to each other, and both were superior to the placebo SSI. So really based on that, I was really convinced that what we need to do to extend on what we currently offer in the UK for young people in the space of early help is to bring these to the UK and figure out how we can make them work here and then test whether they do work in the same way that they do in the States. So essentially, remember here that what I'm going to do in my work, what I'm going to tell you about is what I've been doing, is we're aiming to bring this intervention that's been developed and has worked elsewhere, and to think about how it fits, where it lives in the different context and system of the UK, how we can make it work here in the UK, and then does it work here in the UK. And really, I'm basing this not only on thinking about effectiveness outcomes, but also all sorts of implementation outcomes. So I really like the RE-AIM framework, which is an implementation science framework, which looks at things like who do we reach with our interventions. So in my instance, I'll be really interested in, do people sign up to do this intervention, and who are they? Do they then complete it? This is kind of adoption. Do they actually use it, or do they stop using it after they first started the first couple of pages or first couple of bits of it, for instance? Do they like it? Are they satisfied with it? Is it acceptable? Yes. Is it effective? But also things like how much does it cost, and how can we let young people know about it? And so how can we put it into practice? And really, my funder, the NIHR, of course, their priority is we need to think about how these things will make a real world difference for the NHS and for young people. So that's an absolute priority as part of my work. So what we're doing is thinking about scale out. What I mean by scale out, I've got a slide on that here, is we're bringing something, we're not just doing more of the same in the same context, that's scaling up. We're bringing something to a new context and a new delivery system. We're also thinking about how we might need to adapt the interventions for this context specifically. So we're looking at the interventions and how we adapt them. We're also looking at how we scale out and how we make it live in this context. I've been really guided by work from the Decipher unit at the Wolfson Centre in Cardiff, and particularly Professor Graham Moore's work. And if you're interested in the space of adapting interventions for implementation in new contexts, I would really encourage you to just look at what they did in the ADAPT study. They've got a great study website, and they've got all sorts of super resources that kind of walk you through steps and processes. And so my work is very guided by that. They encourage a starting point of a logic model. Now, I've always been a bit baffled by logic models, I confess. And there are lots of synonyms. These things don't all mean quite the same thing, but I've come to realize that things like theory of change, intervention models, change mechanisms, causal pathways are all kind of really tapping something vaguely similar. And really what I think logic models are is they're meant to describe how we think an intervention works. And so they are a diagram that represents the intervention and its context and its relevant interactions, and essentially summarizes the things we put in, what things people do, what we think that does that leads to its outcomes that we're looking for, that ultimately leads to its impact in the real world that we're trying to generate. And I think I had a ping moment quite recently, actually, where I was like, this is a bit like a formulation. So for those of you who have a practitioner background, I'm a CBT practitioner by kind of model of favor, as it were. And, I've long done formulations with young people. Essentially, this is a formulation of how we think our intervention makes change. So logic modeling our single session interventions, then our inputs are, we need young people to opt in. We need these anonymous interventions that we already know from existing evidence in the States are safe and effective. But we also need the kind of infrastructure to host them on a kind of website where young people can land, find out more about the single session interventions and start getting into them. We need recruitment strategies whereby we let young people know about the existence of these interventions before they might even start knocking on people's doors to ask for help. Then there's all the activities I've already told you about that are parceled into these single session interventions. So goal setting, active learning, psychoeducation, etc. And we think that these work by increasing knowledge, by being normalizing and empowering, by instilling hope. And Jessica's measured hope as one of the proximal outcomes in her work. And she finds that hopelessness decreases, hopefulness increases. We think it improves young people's perceived control and sense of agency. And again, she's measured that in her work as a proximal outcome and found that that is the case. But another thing that my young people's advisory group have particularly said is they think that this could also help some young people because it gives them a language and encourages them to go and talk to other young people about, or other people, pardon me, other people in their ecosystems about mental health problems. So it gives them a language by which they can go and seek more help. So the outcomes we think this leads to, and this is what's been shown in the work in the States, is it decreases depression symptoms, improves quality of life. Potentially, this hasn't been measured as yet. We're planning to measure it in our work, is we think that it could also work by increasing help seeking from other sources of help. And ultimately, we think that leads to the impact of enabling young people to thrive and succeed in their lives and a decreased burden of mental health problems. So I guess I was first of all thinking, well, I'm bringing this intervention from the States to the UK. Does this intervention make assumptions that would be vastly different than for young people in the USA than for young people in the UK? And I guess I was thinking no. I was thinking, I think from everything I know, mental health problems develop and or are maintained in fairly similar ways in young people in the USA and the UK. I think that broadly speaking, I know there are differences, but broadly speaking, beliefs about mental health and therapy seem to be relatively similar. Stigma is relatively similar. Evidence-based treatments that have worked in the US tend to also work in the UK. You know, we know in the space of adolescent depression trials that, you know, generally speaking, the big trials in the States and the big trials in the UK have found broadly similar things. We know that, you know, adolescents are fairly similar, so developmental characteristics are fairly similar. They want to rely on themselves. They want to develop autonomy. So I was thinking, it's not massive amounts of difference. So I was thinking, yeah, we might need to adapt a bit. We probably can't just adopt this intervention as is. We know that there are some differences, the most obvious being things like, you know, the way we use language is a bit different. So things like soccer might need to change to football, for instance. We might need to adapt things, but we can probably assume that it's okay to think about adapting this thing that's already existing rather than needing something completely novel, new, and innovative. So adaptation is really about, you know, reinvention to fit a new context, but maintaining the basic integrity of the core components. So that's what we're thinking we'll do. And adaptations can, of course, range on a whole spectrum from very small changes like terminology or language that I've mentioned to much bigger changes where we might need to change bits of the program or integrate with other interventions. And of course, adaptations too can be planned and purposeful, and that's what we're doing at this stage. But I guess also adaptations can be responsive for the result of drift down the line. So before I started my work, I obviously wasn't the first person in the UK to spot the potential of single session interventions. There had been some work by a trainee clinical psychologist over at the University of East Anglia who had used a growth mindset single session intervention, but it wasn't Jessica's one. It was just a video based one. So it was less interactive and less components of active learning. Young people just watched this 15-minute video that had mainly growth mindset principles in it, but also a bit of self-compassion. And Amaret, who led this work as the trainee, piloted this in 2 schools, found encouraging effects. But her work was very early stage. She was able to say that it was feasible and acceptable to young people, but not much more than that. Jessica Ball, a subsequent trainee clinical psychologist at UEA, then took on this work and ran a randomized controlled trial of the intervention. I was involved in that, and our paper is just about to come out. It's not out yet, but it's just about to come out. So really the headline from that work was it was enormously hard to find young people to get them to do this. We tried on social media, we had very little traction. We tried in schools, we had very little traction. It was desperately hard to get enough young people to sign up to this. The other group that had done some on this before I started my work was Ross Shafran's group over at Great Ormond Street. And they particularly had used Jessica Schleider's project personality, her growth mindset SSI. They had looked at adapting it a bit for the UK context. A master's student had done a program of formative work around that. And then they piloted it for young people who were waiting for help from a psychologist in Great Ormond Street. So all young people who had come to Great Ormond Street because of a physical health problem, but their physical health team coordinators or care coordinators had also identified that they might need help from psychology. They were offered this adapted version of Project Personality. And again, small numbers, I think it was 32 young people, no comparison or control group, relatively short time frame for outcomes, but again, promising, feasible, acceptable. So enter my work, really. And the very first thing I was interested in doing to think about where we position this in the UK was finding out what the key people think about it. One of the key groups of stakeholders here is the frontline professionals. What I mean by frontline professionals is the people who are not mental health specialists, but who might in their day jobs come across young people struggling at the early stages with mental health. So people like teachers, people like GPs, people like social workers, people like school nurses. So I surveyed them, reached out via social media and networks to recruit a sample of 115 of these non-specialists in mental health. If you're interested in this, there is a paper on it. I'm not going to dwell on it, but most relevant to my work that I'm presenting today is I asked people to say on a 1 to 5 scale, 0 to 5 scale, pardon me, how keen they were to know more about single session interventions for adolescents struggling with depression symptoms. I'd provided them a couple of lines explaining what these are, and yay, most were quite keen and enthusiastic. That was good. We also asked them which of various key messages they would endorse as being most helpful for young people. And they particularly liked the behavior activation key message, do more of what matters. They did also think that there was value in the learn to think differently and the learn to be kind to yourself. So the self-kindness project care SSI was particularly also seen as favorable. The other key people to find out what they think about these from is obviously young people. So enter the Can We Connect study. So in the Can We Connect study, we wanted to find out a few different things from young people. One of them was what they think of online single session interventions. We recruited and interviewed 24 13 to 18-year-olds in the UK, and they were a fairly diverse sample. And we did those interviews all online. We did various things, including describing again what a single session intervention is and asked them to share their thoughts about those with us. But what was also particularly special that I want to highlight about this study is we truly co-produced it at every stage. So before we did our interviews, we recruited 4 young co-researchers. They were 16 to 18-year-olds. And we trained them and they co-conducted all of the 24 interviews with us. So each of the 24 interviews, bar one, I think, because of a scheduling issue. So one was just conducted by a research team member, but each of the other 23 was conducted by essentially an interviewer pair, a young person and a research team interviewer. And the young people were very active in interviewing. So they weren't just there sitting on the sidelines. There were bits of the interview topic guide that they were in charge of, and they were very much involved in the interviews. They then worked with us on analysis, on writing up our papers, I should say. They're co-authors on the papers by choice, and also they've worked on various different dissemination projects with us. So what do they think of online single session interventions? Our paper's out there now. It's one of the ones I've linked in the chat. What they thought was they were somewhat skeptical, but also hopeful. They were like, yeah, we think this is potentially helpful, but maybe it sounds a bit too good to be true. It could be a really useful gateway to help seeking, a bit like our young people advisory group had told us, actually. They thought this would be really cool as early help. They liked that it gave young people control, that they didn't have to disclose, and that there would be no stigma attached to seeking this anonymous on-demand help. It would increase access. But they also had all these like, have you thought about kind of questions, and this was all about logistics for implementation. So like, we're not sure if the right place to advertise is social media. We're not sure, can something that's appropriate for a 13-year-old also be appropriate for an 18-year-old? And do you know what? How do we know we can trust something? Think about how you share information about it in ways that we can know we can trust it. So they really got me thinking more about the implementation piece. And in that, I was revisiting my thoughts about, is the USA so different than the UK? And a few light bulbs went off for me, like, yeah, we have quite a different healthcare system, don't we? NHS is free at the point of access. When you say in the States, I've got this free mental health help, it means something different to the UK, because in the UK, it's like, well, NHS is free. We've got all sorts of other kind of minor differences, but essentially in my learning, one of the key things that I've had to think about, two key things actually, is one, Instagram doesn't seem to get the leverage here when we say free mental health resource than it does in the States. But the other is we've got different consent processes and different laws around consent. So I've had to think about that too. So this really then led on to further formative work to address some of these uncertainties. So key question, where do we put this? How do we let young people know? And so I had to think about not just the logic model for the intervention itself, but the logic model for our implementation. How and where do we put this? And ultimately, what I thought we needed to do to share it is put it where young people already are spending time looking for information, help, and support. And so return to the Can We Connect study. One of the other things we were asking young people is, where do you look for help, especially in the online space? What do you think of the things you find? And also we asked them to screen share. We watched what they did in searching for mental health issues. We'd given them a scenario of like, Sally's 15, where would she look online? These are the problems she's having. What do you think of the things that come up in your Google search? They all use Google, by the way. We didn't tell them to. They all use Google. And then we showed them some kind of screenshots of things that are out there already to get their views on those too. And we found all sorts of really interesting things about where young people look, how they look online. They look at different kinds of things for different kinds of information. So they like the NHS for trusted medical information, but they find it quite impenetrable and not very well laid out or formatted, not very accessible. They like charities like Young Minds for more specialized support that they do trust. They go on social media because they find it very validating, but they don't think it's trustworthy. And they told us all sorts of interesting things about the look and feel of information and ways that they would assess things for trustworthiness and credibility. So again, our paper's out there, linked in the chat, and we have co-produced guidelines that we worked up with our young co-researchers about how and where to share information about youth mental health online. So do have a look at those if that is relevant to your own work. We've also done various pilot studies using the single session interventions as kind of single arm, immediately pre-post, just to test out some of our recruitment strategies before we go to full trial. So we offered Project Care, for instance, which is the self-kindness SSI. We offered it widely in all sorts of places. Again, our paper's just been accepted for publication on this one, reporting the results of our pilot study. But most interestingly and most relevant to what I've been talking about today is what we found is, we did a huge amount of work on Instagram. No one signed up through Instagram, really. We didn't reach anyone. But what was most successful in garnering signups was sharing information about the support available through the study. So the study details on platforms where young people are already looking for early help, anonymous online support like Kooth and Shout. So that's really helped us to shape our planning going forwards for how and where we'll share this. And looking at the program feedback we get, so we ask a number of kind of Likert scale questions, 1 to 5, really disagree to really agree on things like I enjoyed it, I'd recommend it to a friend. Looking at what we got on Project Care, obviously it's not for everyone. There are some young people who don't like it, but on the whole, it's getting quite favourable feedback. And our immediately post outcomes like improving hope and reducing hopelessness, improving perceived control are in a favourable direction. So we think that what we will do in the long term in the UK is that we'll signpost from places of young people already looking for support and help to our website, which we've been co-designing over the last year. This is just a screenshot, but we've had young people involved in co-designing this at every stage. We will be publishing a paper on that process in due course. They'll land there, they'll find out more about what single sessions are, there'll be some testimonials, there'll be information about other sources of support, but it'll also be the front door into the SSIs. The other thing we had to crack was how we'd kind of evaluate these in the UK context, keeping them barrier-free, so not requiring parental consent for young people who are under 16. If you're interested in that piece, we worked with our young people advisory group and young advisors to really develop a process and then explore feasibility and acceptability of that process, to using multiple choice questions after our information sheet, before our consent form online, that enable us to assess Gillett competence for under 16s. In other words, do they understand what the study's about, why it's being done, what the risks and benefits are of taking part? So the last piece, which is work in progress, watch this space. We're just busy now planning for our effectiveness work. So we'll be doing a 3-arm randomized control trial, a bit like the one Jessica did in the States in the pandemic context, comparing the growth mindset single session intervention adapted for the UK with the behavioral activation project ABC adapted for the UK with the placebo control adapted for the UK, and have both superiority and non-inferiority hypotheses. So yeah, we're adapting the SSIs for the UK context. We've been doing all these pilot studies. We're working with our young people's advisory group. And some of the key questions we're trying to figure out right now is how in a self-help anonymous single session intervention do we monitor for adverse events and harms? We're working on that with our young people advisory group, who are co-designing questions that we can use, but also we've done a mapping review to look at what other digital self-help studies have done in this space. And we've got various PhD students who are specifically thinking about how we leverage these single session interventions for specific populations of young people. So Emma's working on LGBTQ plus young people, where, by the way, in the States, huge amount of LGBTQ plus young people have signed up to the existing studies. Sophie is working on thinking about these for the global majority. In the UK, that's the ethnic minority young people, but she's also thinking about how we might use these in South Africa for helping to meet the needs of young people there. Natalia is working on developing a single session intervention for parents to support them to support their teen with adolescent depression symptoms. And we're also, as part of the new Mental Health Research Group Award to the University of Bath, going to be looking at how we can also leverage these for 19 to 25-year-olds in the UK. So on that note, I will stop talking and invite questions. As I say, I have circulated Holly links to share with you, but also if you're interested in the space, Jessica wrote a fabulous book on single session interventions a couple of years ago that I really recommend. But also Jessica and I both have podcasts on the ACAMH, and also there's some really great papers out there from Jessica's team and from myself and Jessica too, that will allow you to explore more. So thank you so much, and I'll stop sharing now, Tamsin.
Not usually that efficient. Thank you, Maria. That was absolutely brilliant. So many questions. So if you're online and you've got a question, please raise your hand, and I'll start with questions in the room. Clara.
Thank you, Maria. It's always really nice to see your talks. So I have a question about a point you mentioned towards the end. So recently there's been a bit of noise in the media and also some researchers showing potential harms of like blanket school mental health based interventions. And as you mentioned yourself, one of your next steps is kind of try to figure out what would the potential harms be around single session interventions, thinking that it's like a blanket approach. And I was just wondering if, based on your young people's advisory groups and also based on your own like conceptualization of the interventions, like, do you think there are any potential harms? And if there are any harms, like, what do you think the harms could be? Thinking about like, not thinking about safeguarding as much, but thinking more about like harms of the intervention itself, if there's any.
I mean, I think it's absolutely key to consider harms and to acknowledge that any psychological intervention has the potential to harm. And I think we haven't been very good as researchers or indeed practitioners in the space of acknowledging that. And I think it's something we need to get better at and more thoughtful at. And to work out what works for whom, we also need to work out what doesn't work for whom. I think the key difference of these single session interventions as compared to some of the universal school interventions is the intention here is not to mandate that everyone uses them. It's to offer them as an opt-in for people who want to use them. I think much of what happens in a universal school based approaches space is young people have to receive the mindfulness training or whatever it is that's being offered. I'm thinking of a Myriad study. If you're at a school that was